Good morning, everyone. Welcome to one more lecture of Pediatrics, and that is about fluids and electrolytes, as well as we are going to discuss some common complaints of pediatrics. Now we are out of neonates, right? So we will discuss the common complaints of pediatrics. There are different things which are there, for example, the behavior of the child and all this stuff. So we are going to cover all these things in this lecture. So first of all, what we are going to discuss is the fluids and electrolytes things, and of course, like why this topic is important, because one of a very common complaint or the situation is dehydration, okay, in kids in pediatrics. Of course, the dehydration can occur due to different diseases or conditions, you can say. The good thing, like in general surgery, I think we had a huge discussion about the different type of fluids which are available and which we can give to the to the people, to the patients, right? And I've already explained, what is the total body water and how much is in the ICF and how much is in the ECF. Like as a rule of thumb, you can say like the total body water, what is inside, basically two-third is intracellularly and one-third is extracellular fluid. And out of that one-third extracellular fluid is basically most of that, like 75% or three-fourth of that is basically in the interstitium, as well as one-fourth or 25% is in the intravascular, or what is running as the blood, right? And what we can manipulate or what we can add up, or what can be lost, okay, is basically the intravascular fluid. Like whenever we give some IV fluids, this is the one, and this is the body compartment which we are going to play with, right? So simply, the causes of dehydration in pediatrics is, again, not just pediatrics, like oral in medicine, can be due to two main reasons. Either there is decreased intake uh, of the fluid, or there is increased losses, okay, are there. So if we will talk about the decreased intake, the important thing to know here is there could be poor oral intake, okay, as well as there could be like poor oral intake in case of different infections or different diseases, like or acute illnesses, like uh, when the children they stop taking uh, fluids, okay, or the diet. For example, breastfeeding difficulties, right, are there. Breastfeeding difficulties can be there, simply because of that, like the like some babies, they are taking less amount of fluids. And the other one is increased losses, and in that one, diarrhea makes a very important part, as well as vomiting is also a very important thing, or bleeding, for example, not so common, but of course it can occur. So this thing can be there. uh, so you can say like these are the GIT losses, which like the babies may have in the form of diarrhea, vomiting, and bleeding. um, Fever is one of the condition when uh, there is increased losses, okay. Burns can be there, okay. And now, uh, one cause of the dehydration um, can be due to diuresis or osmotic diuresis. For example, in hyperglycemia, of course, can occur in both adults as well as the babies, okay. Or one of the thing is, diabetic ketoacidosis, in which the patients, when they present, they are dehydrated. So this thing, diabetes insipidus is one of the condition in which, like, the patient can present uh, with dehydration. Okay, so this thing, and there could be a number of the reasons, like we there is insensible water losses from the respiratory tract. For example, a baby who have tachypnea, of course they will be losing a lot of the body fluids, from the respiratory tract. Of course, in pneumonia and bronchiolitis conditions like this, uh, when the patient have can get go into dehydration because of increased losses. So, what is important thing over here? Uh, like, of course, I will not go into too much detail of this thing because we have already discussed this thing in surgery. What are the signs and symptoms we see in dehydration? For example, uh, we check the mucous membranes. We check the what you can say capillary filling time. We check the pulse. We check the blood pressure and all these things, right? Um, in babies or even in adults, okay, but like because we are studying pediatrics, so I will keep on saying what you can say children. Of course, like we have to take the history first of all. Okay, in history, what we have to cover, we have to search for all these things, right? Uh, what is the thing which is causing dehydration? Either it's decreased losses, or increased losses, or decreased intake. Okay, and or either it's some sort of infection which is going on. Okay, we are going to take the history to reach out the cause of the dehydration. Okay, so we search for all these things, in this one, and then we go for the examination. And we see in examination we take the vitals, of course. Okay, we check the um, uh, level of consciousness. Okay, uh, because this one uh, can be disturbed. Okay, can be reduced. The child may appear lethargic. The child may appear in coma, for example. Okay, we always check like either the baby is having any thirst or not, right? When the babies are small, one very, very, very important thing which you have to remember is like we always ask the mother in history, by the way, you can ask the mother about wet diapers. Okay, how many diapers she's changing in one day. Okay, so for example, if the mother is saying that she haven't changed any diaper since the morning and it's now the afternoon or night time or in the evening time, of course, like it means the baby is dehydrated, and that's the reason that uh, uh, maybe the baby needs some uh, fluid therapy. Okay, so whenever like we found like some child is dehydrated. Okay, so we have to do assessment of uh, you can say degree of dehydration. Okay, degree of dehydration. Okay, so how we can assess that is simply by looking at many things, and we can simply um, we can classify them according to their status. Either it's mild, either it's moderate, or either it's severe type of dehydration, right? So I'm inserting this table. Okay, I don't know either it's like enough or not, but like I will try to fit the things inside. So you can say one is mild dehydration, one is moderate dehydration, and the last one is severe dehydration. Okay, um, uh, how we can assess like there is some change in the water content of the body, is there, if there is any or not, is basically we go onto the body weight. Okay, we check the body weight, and simply uh, by checking the body weight, we can assess like either the child is losing um, what you can say um, have lose any water or not. Okay, so for example, a baby who is weighing whose weight was like 10 kilograms today, and the baby is admitted into the hospital, and uh, the baby have vomiting and diarrhea. So if the next day you will check the weight of the baby and you will found that the baby weight is 9 kilograms, so how much weight the baby have lost? It is around 10% of the body weight is lost, right? So there's a different criteria for the babies who are less than 2 years of age, as well as different criteria for the babies who are more than 2 years of age. Okay, so less than 2 years of age and more than 2 years of age. So any baby who is less than 2 years of age, when they lose 5% of their body weight, it is considered as mild. 10% of their body weight is considered as moderate, and 15% of body weight is considered as severe type of dehydration. Okay, but any baby who is more than 2 years of age, any child, 3% is considered as mild, 6% considered as moderate, and 9% is considered as severe. Okay, so simply based on the pre-illness and post-illness body weight, we can assess the dehydration level. But not just this thing. Basically, we go for example, we can check the pulse, we can check the blood pressure, you can check the urine output, okay, as well as you can check the mucosa, okay. You can check the what you can say when the babies are very small, so we can check the anterior fontanelle if it is not closed yet, right? So I don't know, like insert columns to right, insert rows below. Okay, very good. So we can add more rows. So I will add more rows. So in what you can say, the babies who are very small, we can talk about, and we can check their anterior fontanelle, right? Of course, like if the fontanelle is, it is mostly in babies who are less than 1.5 years of age, right? Not uh, below that, not above that, of course, because their anterior fontanelle is closed, right? We can check their eyes, as well as we can check their skin turgor. Okay, these all things you have discussed in surgery, and we can check their capillary refilling time. Okay, so in mild rehydration, basically, mostly the pulse is normal, the blood pressure will be normal, the urine output, of course, it will be decreased, the mucosa will maybe slightly dry, right? Anterior fontanelle may be normal, eyes will be normal, skin turgor will be normal, and CRT will be normal. Of course, like we consider CRT normal whenever it is less than 3 seconds. Whenever it is more than 3 seconds, we can say that the CRT or capillary refilling time is abnormal, right? Whereas in moderate hypertension, or sorry, moderate dehydration, the pulse become rapid, increased. The blood pressure can be low, but can be normal, okay? But of course, urine output will be decreased, okay? Mucosa will be dry, anterior fontanelle will be sunken, depressed, eyes will be sunken, skin turgor will be decreased, okay? Whereas CRT will be maybe normal or maybe increased more than 3 seconds, right? But whenever there is severe dehydration, guys, now see, this is the time which, like, their pulse will be rapid and weak because there is less intracellular fluid, okay? Blood pressure will be low for sure. Urine output, maybe there will be anuria, no urine at all. Mucosa will be completely dried, okay? Anterior fontanelle will be sunken for sure, okay? Eyes, of course, dry and sunken. Skin turgor, tenting. When you will pinch the skin up, it will not go back, or it will go back very slowly. But and CRT will surely be reduced, okay? like increase for more than 3 seconds. So this is how the patients will present, right? So a very, very, very important thing, guys, which I think, not I think, every doctor, every medical student, every working person should know. This is something which can kill, okay? This is something we must do in our assessment, because either the child need like fluids or not. And now, again, we have discussed that thing. Basically, there are like sodium is basically the main extracellular ion, and the potassium is the main intracellular ion. Okay, and there is bicarbonates, there is chloride, there is magnesium, there is all these things. Okay, so the body fluids, uh, they have different contents of sodium, potassium, chloride, as well as bicarbonate. For example, uh, the secretions from the small bowel have a lot of sodium, okay, whereas like the saliva or sweat, the sodium contents, if we will calculate in millimole per liter, is not so high. Same thing with potassium. Like potassium per liter of small bowel fluid, which we lose around 20 millimole per liter of potassium, and we do lose chloride with that, we do lose bicarbonate with that, right? So whenever it comes from the large bowel, the contents of potassium become more higher, but sodium is around 70 millimole per liter. Okay, so uh, of course, like we check, like either the baby have vomiting means like gastric fluids are lost. Okay, either the baby have diarrhea, so of course like the GIT contents are lost, or the intestinal contents are lost. So mostly we don't go for investigations if it's a clear-cut case of dehydration with some infection, but sometimes we do go for investigations, okay? And especially in moderate to severe dehydration, and we can do like CBC to look for infection, we can do ESR and CRP to check for any infection signs, okay? We can do ABGs, atrial blood gases, to see either there is any acidosis or alkalosis, whatever is the condition. Okay, we do check for renal function tests to see like either the kidneys are affected or not. And very important thing, we always do electrolytes to check either there is any hyponatremia, any hypernatremia, hypokalemia, hyperkalemia, and things like this, right? So uh, these investigations can be done, not always done, can be done, right? And then what is our plan? Like our main discussion or our main decision is either the child needs you can say rehydration therapy or not, right? This is the main point, which we are struggling to take out. Okay, so why? Because if the child is dehydrated, so of course like rehydration is very important, and we have to provide two things, by the way. One thing is like we have to you can say replace the ongoing losses, plus we have to give them maintenance fluid, right? We have to one of the first thing is we have to replace the ongoing losses, and the second thing is we have to give them the maintenance fluid. Okay, so whatever is the case, we decide either, okay, first decision is this one, number one, either the baby, they need rehydration therapy or not. And the second decision is what? Either the patient, okay, the patient is a good word, by the way, what you can say, can take oral rehydration or not. Okay, because like if the patient can take oral rehydration, so of course like we will give them oral rehydration therapy. Okay, and what we give in oral rehydration therapy, we give them ORS. Okay, WHO says that everyone should know how to make ORS at home. I don't know how many of you know or not know, but ORS we can make at home, and we can get it from the what you can say uh, from the medical stores or like many shops, right? So, but WHO says uh, everyone should know how to make ORS. Like, what is ORS? Oral rehydration solution. Okay, at home. Okay, why? Because not all the world is same. Not everywhere there is all the you can say things are available. A very easy thing, you can take 1 liter of water, or if it's a clean water, bottled or mineral water, that's fine. Otherwise, you can take water, you can boil it at home. Then you have to put uh, uh, half leveled, I'm using the word leveled, teaspoon of salt with 6 level teaspoon of sugar, and just mix it up, and your ORS is ready. Okay, and you can give it to the patient, right? So see, oral rehydration solution, it is like low cost. uh, it can be given by mouth. Okay, there is no risk of having hyponatremia or hypernatremia, because the body can adjust themselves. So there are many, what you can say, uh, advantages and disadvantages of ORS. Like, not disadvantages, like advantages of ORS. Of course, it's you can make it at home simply. Okay, so this thing. And if someone who cannot take by mouth, then of course we go for IV rehydration. Okay, and of course, this topic I'm not going to discuss more. We have discussed this thing a lot. What kind of fluids are there? I told you normal saline. I told you what is ringer lactate. I told you what is Hartmann solution. I told you all these things, right? But simply, guys, whenever there is severe dehydration, we go for IV rehydration. And someone who is vomiting, someone who have diarrhea, someone who have altered mental status, and anyone like this, we go for IV rehydration therapy. And of course, like, we have to keep on monitoring them, monitor the patient. Okay, monitor can be, either there is any they are becoming overhydrated, or monitoring can be the monitoring of the electrolytes, and monitoring can be of all these things. Okay, so uh, anyone who have all these things, of course we go for IV rehydration therapy, right? So now uh, once you have done the IV rehydration therapy, then of course, uh, like we wait until the baby is well hydrated. Okay, and once the baby is well hydrated, uh, then of course, like, what we do is, um, we, like, for example, if the baby is too much sick and he was on IV rehydration therapy, so once you believe that the vomiting and the infection or the diarrhea, or like the things are settling down, and the child is now can tolerate oral feed, so of course move them on the oral feed. So of course, after that, we start them with a soft type of diet, and of course, if the babies are drinking milk, so we give them that. Okay, so this thing, normally in mild dehydration, and if you're using ORT, we give them 50 milliliter per kilogram. Okay, like over 4 hours. Okay, this is the thing, which we can do. But in moderate, in mild, okay, in moderate, we can increase that thing to 100 milliliter per kilogram. Okay, in moderate, of course, over 4 hours. Okay, over 4 hours, like this way. But of course, like in severe dehydration, of course, like, oral rehydration therapy is not given. Rather, we go on IV rehydration, right? So in that case, of course, you must know how to give them. Like a very easy rule you can remember, like normal saline is the most commonly resuscitation fluid, or ringer lactate are used, okay, most of the time, and we can give them in severe dehydration. I'm talking about. We can give them 20 to 40 milliliter per kilogram, okay, uh, over 1 hour. Okay, a very easy formula, guys. For 20 to 40 milliliter per kilogram. For example, if the baby is 10 kilograms, so you can give them 200 to 400 milliliter in 1 hour in severe dehydration. And once the baby can take oral feed or is feeling fine, of course, we can move them on oral rehydration therapy. Okay, so this thing is important. Now, by the way, if we are discussing this thing, okay, I can tell you a very, very, very easy way to remember what you can say, um, how to calculate, I can say, how to calculate um, maintenance fluid requirements. Okay, so now very easy way to calculate the maintenance fluid requirements is, again, I'm going to insert a table. Okay, so we can insert a table over here, and sorry, okay, so now this table is there. For example, on this side, when we can write body weight, okay, and here we can write, for example, for the first 1 to 10 kilograms, okay, what you can do for the next 10 kilograms, like from 11 to 20 kilograms, what can be done, and anyone who is more than 20 kilograms, so what we can do for the rest of the, like the weight. Okay, how much fluid can be given, okay, or you can say the 24-hour maintenance fluid, okay, which is needed, can be simply remembered by a very, very, very what you can say, easy rule. That rule is called as 100 ratio 550 ratio 20 rule. Okay, this one, what it means, see, remember this rule, 100 50 20. Anyone who is 1 to 10 kilograms, we have to provide them 100 ml per kilogram per day. Okay, for example, if you have a baby of 6 kilogram, how much the baby need? 600 milliliter per day. If the baby is 10 kilogram, how much they need? 1 liter or 1000 ml per day, right? So easy. What happens, for example, if you have a child who is 15 kilograms? Now the things will change. So the first 10 kilograms we have to provide how much? 1000 ml, right? So 1000 ml, of course, for the first 10 kilograms of the baby, then we will provide them with 1000 ml. And for example, the baby is 15 kilogram. So all the rest of the weight, like the next 5 kilograms, we have to add 50 milliliter per kilogram per day. Okay, so like for every kilogram, you can say more than 10 kilograms, right? Very easy. So what it means, guys, see, what it means is any baby who is coming with um, like 15 kilograms. So for the first 10 kilogram, I will provide them 1000 ml, and for the next 5 kilograms, I will add 50 for each one. So a 15 15 kilogram baby, 15 kg baby, and needs how much? Needs 1000 for the first 1 kilogram, 10 kilograms, then 50 I have to add for the next 5. So 5 multiplied by 50 is equal to 250 ml. So this baby needs, a 15 kilogram baby needs 1250 ml of fluid, right? This is like, for example, like example purposes, I'm going to, I paste it over here. Now, for example, if someone, a baby who weighs 20 kilograms, how much does he need? For the first 10 kilograms, 1000, and then each kilogram after that, I'm going to add 50. So that makes 1500, right? So 20 kilogram baby needs 1500 ml or 1.5 liters simply, right? So any child who's more than 20 kilograms, guys, for the first 20 kilograms, how much they need? 1500 ml, right? So that will make 1500 ml. Plus, you will add 100, 50, 20 rule, 20 milliliter per kilogram per day for every kg more than 20 kilogram, right? So very easy, right? Very easy formula, very easy to remember this thing, okay? And if you can remember this thing, you can remember what is the maintenance fluid requirement, right? And how fast you can give, okay? Like as I told you, in the first 1 hour you can give 20 to 40 milliliter, okay, to a severely dehydrated. So how fast you can give, or you can say like what is the hourly rate of maintenance fluid, right? So that can be remembered by 4:2 ratio 1 rule, right? So for example, we provide 4 cc or 4 ml of fluid per kilogram per hour, okay? What it means, guys, if a 10 kilograms baby is coming, you have to provide them with 1000 ml of fluid, and how much fluid you are going to give them is 4 multiplied by 10, okay? 10 milliliter per hour, okay? You have to give them what? 10 milliliter in the first hour. Sorry, 40, sorry. Um, uh, 10 kilograms, so 10 multiplied by 4, 40 milliliter you will give in the first hour, in the per hour, right? And same thing for a 10 kilogram baby, you have to give 40 milliliter in 1 hour. So anyone who is more than 10 kilograms, so remember, right, 40 ml, this one you will add, of course, right? Plus it is 4:2:2 1 rule, so 2 milliliter per kilogram per hour for every kilogram for every kg above 10 kg, right? And same thing here. So how much for 20 kilogram baby? It will be 40 plus 2 for each kilogram. So 2 multiplied by 10 is equal to 20. So 40 plus 20 is equal to 60. So 60 ml for 20 kilogram baby, 60 ml per hour, right? And anyone who is more than 20 kilograms, of course, like how much we can give? 60, which is coming from the back, ml, plus it is 4:2:1 rule. So 1 milliliter per kilogram per hour for every kilogram above 20 kilograms, right? Very simple rule, right? So this is like how to calculate the maintenance fluids, okay? And remember, guys, for the children, whenever we choose the maintenance fluid, we always choose like the maintenance fluid should always have dextrose or glucose in that, because the children, they are at increased risk of having remember, hypoglycemia, right? So always choose when we are talking about the maintenance fluid, so always choose a fluid what you can say, which must have dextrose, okay? Because the children may have hypoglycemia, okay? So few rules you can say, always choose dextrose component, okay, to avoid hypoglycemia, right? So for example, in newborn babies, dextrose 10 water can be used, okay, in newborns, because they are at increased risk of getting hypoglycemia. And simply like this thing, right? Dextrose 5 water is the one which is available normally in the hospitals. So we can use dextrose 5 water with half normal saline, and if needed we can add potassium in that, or we can add um, like we can combine dextrose 5 water with normal saline even, right? That's all these things are fine. So uh, general rules, follow the general rules, which are the rules which we have already covered. Never correct the sodium levels too quickly. Of course they can cause cerebral edema, okay. uh, so remember this thing, okay, very 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 important thing. And by this way, we calculate the fluid requirements, okay. And of course, like, keep on monitoring. If you're uh, like remember, like, what you are putting, like the intake, sorry, or the input should be equal to the output. If you are talking about the maintenance one, for example, if you're giving per oral plus what you are giving in IV form, okay, should be you can say in what you can say should be we should keep in mind these things and compare and see the output. For example, what you can say, if the urine output should be measured, right? As well as if the baby have diarrhea, so add that, okay, how much the baby have already lose, plus if there is any drains, okay, or for example if the baby is vomiting is there, okay. So like these things should be uh, seen, and keep on monitoring about the changes of electrolytes, okay, hyponatremia, all these things. SIADH is a very important thing, syndrome of inappropriate release of antidiuretic hormone. Again, I don't know like how many of you know about that thing, but like that thing is very important to consider, right? So this is like about what you can say, the normal things, about the fluid and electrolyte levels, which I wanted to talk about. Then the next topic which we can discuss is like common complaints. I don't know, like in this 1 hour we can complete this thing or not. So maybe like the next lecture will be about that one as well. So like the common complaints, like there are certain complaints which are psychological, like which are like which plays with the child psychiatry. I would like to discuss them in the start, because after that we will talk more about medicine, okay. So we must know the normal things, how the child behave, okay. The children have different emotional responses, they have a different personality, and mm, all this thing depends on the parenting style as well, and that's why how the parents are, their kids are same like that, okay. You will found in the home, if one people, like you will found like generally in some homes, like everyone talks so loudly, okay, or like, because the parents are those who are nurturing, or who are educating, or who are grooming their kids, okay. So of course the kids, they learn from the parents, everything. So what we must follow is like good parenting skills to parent our kids, okay. Of course, like children, when they grow up, of course, they have their personality, which have a big huge impact of how is the personality of their mother or father, okay. So like when the babies are born, of course, for the first 2 months, they are not so fussy, or uh, if you keep on responding to their needs, when they are hungry, just keep on providing them milk, so they are not so much fussy. But As they grow up, they become very much selective, choosy. Okay. And especially when they are like more than 6 months of age, um, they develop a lot of things like something called as separation anxiety. Like if like if you will hold a baby who is 3 months of age, like the baby, maybe he will just keep on looking at your face. But if you will hold a baby who is 8 months of age, if the mother is not around or the father is not around or someone who is not around, they know them, they started crying. And this is something called as separation anxiety is there. Okay, so they develop the separation anxiety by that time. Okay, around 6 to 8 months of age. So they basically, before that time, they are basically the registering the details. Like when they see someone's, they keep on looking at their face and they see, they they register the faces, and then they know, okay, who is the one who I can trust and who is the one I cannot trust. Okay, so like this way, so like we must know the normal things, and then we can talk about the abnormal things. Okay, this is very important. So like uh, if the child is parenting, like if the mother and father, they're parenting child in a very good way, like providing both physically and emotionally, and protecting the child from any harms, like many of the children who become like criminals, and like when they grow up, had bad histories in the past. Many of them, they were sexually abused. Many were as a result of broken marriages. Okay, so of course, like provide affection, support, comfort, food, and shelter. These kind of things to the babies, of course. Like, and when you respect your children, they respect the elders. Okay, so it's a give and take type of thing. Okay, and like there are many what you can say good parenting skills are there, which also says that keep the adult businesses away from the children, like sex. Don't do it in front of them, of course. So like this thing. So anyhow, what I wanted to talk about is like how they develop the personality, and it is one of my favorite subjects, like which I had dig a lot. Okay, how we develop our personalities. So of course, like this is one of the part of that. So uh, like all the things which you will study, especially in psychiatry, you will found that uh, much of the things, like the personality of the child is basically developed like from the first day of their life. Okay, uh, if someone like if the mother will keep on giving them good care, of course they maintain a very close relationship with the mother. And whenever they are separated from the mother, they started crying. Why? Because they know this thing. And of course, like they have a different temperament from the adults as well. uh, for example, some of the child, they have like a difficult type of temperament. They have a lot of negative mood. They cry a lot, they moan a lot. Some of the children, they have a different temperament emotionally. Things like this, right? So every child have its own temperament even. Okay, and they have their self-esteem, they have their all these things, are different in child simply. Okay, so especially the child, like any child, when they become ill, and especially when they have chronic illnesses, guys, they they had very serious mental issues because of this chronic illness. Okay, so of course, like nowadays there is child psychiatrists as well. Okay, so regarding the common complaints, psychologically, you can found any type of complaint, like in preschool children, they have sleep disturbances, they have like they have some playing problem with other kids. In school going, you will found a jealousy child, a child who is always in anxiety, educational problems you will find, uh, things like this. And adolescents have their own problems, like sexual problems are there, relationships or problems are there, and things like this. So everyone have its own, what you can say, things. So one of the thing, by the way, which we can discuss is called as breath holding spells. Okay, not so common, but okay, they can occur, and they occur in healthy childs. Okay, like the children who have breath holding spells, they are basically healthy childs. Okay, healthy children, and they mostly occur in under 4 years of age. Okay, so what happens, like when the babies are provoked, the provocation can be due to anger, injury, or fear. They hold their breaths and they become silent. Okay, now when they hold their breath, sometimes they hold their breath and they turn blue, or they become cyanotic, which is a very common thing. So, and that cyanotic type of breath holding spell is usually associated with anger or frustration. So why I'm talking about this one, because many uh, parents, they come to doctor and complain that their child have epilepsy. Okay, but you should differentiate how a epileptic fit look like and what is breath holding spell. Epilepsy is highly connected with, what you can say, the history of epilepsy in the family. So most of the children, who have breath holding spells, it resolves spontaneously. Just, we tell the parents to avoid the situations in which, like, the child, they show these kind of behavior. Avoid those situations, and don't be the audience. If, like, these kind of things, temper tantrums and all this stuff, they need audience. You throw temper tantrums when like someone is someone is there to look at you, right? If you are alone, and if you do know, like, there is no audience at all, by the way, you are not going to throw any temper tantrum. So this is one of the thing, we tell them that what you can say, don't be the audience, right? And once you are not audience, and avoid the situations in which, what you can say, the child is showing such behavior. Okay, for example, some of the babies, they are very crying or fussy child. Okay, so I will write over here, fussy child. So they have problem with feeding, sleeping, crying. Okay, sometimes, of course, they become fussy due to some infections, like when they become sick, like fever, or they have some infections. Okay, so sometimes after vaccination, sometimes it is due to drug reaction and stuff like this. Okay, so whenever there is any crying child, especially with a child who cannot talk, so of course we go for physical examination. Okay, we try to look out the things, like either the baby have any physical, like, abnormality or not. For example, we can do the physical examination, check like their fontanelle, check their tympanic membranes, check their nose, check inside mouth, especially check their eyes, because sometimes it can be child abuse. Check them neurologically, check their chest, check their tummy, ask about their bowel habits. Okay, in males, check the scrotum as well. There could be some problem with the testes. Check their anal region for any anal fissures. So all these things, should be checked. And if we could not found anything, of course, like, then we say that, okay, the child is having like, it's a fussy type of child. Okay, one thing which you will found is infantile colic. Okay, Okay, it is very, very, very common thing, guys. And what is that? How we can define infantile colic is basically this is unexplained, you can say, paroxysms of irritability and crying for more than 3 hours per day with greater than 3 days per week. Okay, per week for greater than 3 weeks. So this unexplained paroxysm of irritability and crying for more than 3 hours per day for more than 3 days per week for more than 3 weeks in an otherwise healthy child. Okay, healthy child, well fed, who is taking. Remember, when the child is feeding well, pooing well, playing well, the child don't have any problem. Okay, and it is so common, like up to 10% of the infants they show such thing. Okay, and the peak time is around 6 to 8 weeks of their life. Okay, the parents, they become completely worried that what happened to their child, and they cry for more than 3 hours. It's very hard to soothe them. It is believed that, like, in our country, they say like the child have gas, by the way. Okay, but what is believed that it is due to a lag in their development of normal peristaltic movement in the GIT, and that's why, like, they have some pain in the tummy. Okay, so whenever the parents they have such a complaint, so always educate them. First of all, try to look for any organic cause. If you couldn't found that, um, educate the parents, tell them what is the condition, tell them that it will go away, tell them the trip 4S technique. I don't remember exactly, but it is like soothing and soothing and things like this. Many of the babies, they feel good, they feel uh, they calm down. Like if you will turn on the hoover, the vacuum cleaner in the home, some child, they become good when they listen to some music. Some children, they become good when you will take them for a ride on a car. They don't know what is car, but they feel good. I don't know, like they keep quiet. And I'm not making it for myself, guys. It's written in the books. You can take your baby for a car ride or turn on the vacuum cleaner. Always check the nappy before that, of course, which is very important. Maybe the child is crying because of a rash in the nappy, or because he have done something like pee or poo, and that's why he's disturbed. Okay, there are many preparations available all over the world. One thing is called as gripe water. I wish I can Google that thing. Right, gripe water. I'm sure you have seen that thing. Okay, so there are many preparations in different countries. I know the name of gripe water. Okay, it has no proven benefit, guys. Okay, one of the way, one of the, like, many things are tried. The 4S techniques, I was talking about is, like, I think swooshing, swaddling, and something like this. You can write it down and you can search it yourself. Sometimes, what they found, like, elimination of cow milk protein from the mother's diet helps in few percentage of the cases. So what we tell the mother is to stop taking or eliminate all the things in your diet which have the cow proteins, like milk, yogurt, things like this. Okay, uh, guys, we cannot label anyone with infantile colic. Okay, if you have not examined, always examine, always check the tympanic membrane, all that stuff which I told you about, what to do with the fussy child, right? And then label the child with this kind of thing, not before that. So most of the patients, most of the babies, it's like it resolve on itself within 2 to 3 months of time. But guys, 2 and 3 months is a long time, especially when you think about coronavirus and you are in quarantine for 15 days. Even 15 days are long. So 2 to 3 months of life when the mother is completely disturbed, she couldn't sleep, her life is changed, she's dealing with the baby, so it is very, very, very hard. In many of the children, they try to they tell the mothers or the parents to try casein hydrosylate formulas. If you will go to the markets, you will see on the shelves something called as Nutramigen. Okay, Nutr Nutra Nutramigen. It's a company name, but available worldwide. Okay, available worldwide. Dentition. These are the few topics which are not so important, but I'm just covering it like with this fluid and electrolyte topic. So I think like all of you know, because you were babies at some stage, all of us, we have primary teeth, which is called as primary dentition, and we all have secondary teeth, which we have in our mouth, which is secondary dentition. How many primary teeth are there? 20. How many secondary teeth are there? 32. We all know, right? Very easy. So, by the way, uh, all the children, they behave in a different way. I know children who born with first tooth in their mouth. I know children who don't have teeth until 1 year of life. Okay, but most of the child, their first tooth appear in the when they are 5 to 9 months. Okay, and what tooth is that one? That is mostly lower incisor. Okay, so this is the timeline when their first tooth is erupted. Okay, and after that there is one per month. Like each month there will be one new tooth. Each month there will be one new tooth. Okay, so most of the babies by first year of their life, they have 6 to 8 central teeth. Okay, so this is like the normal way. And then, of course, like their milk teeth, we call it as milk teeth, in our country, or like I think in most of the countries they call it as milk teeth. uh, Most of the children, the first adult tooth is the first molar. Okay, which they had around 6 years of life. Okay, when they are 6 years, and then there is like lower incisors which are there. So one thing I would like to tell you is sorry, I lost the track. Okay, one thing I wanted to tell you, talk about here is something called as milk caries. Okay, like if you know what is caries, that blackish type of thing which you can see in your tooth, and after that, sometimes you had pain in your tooth as well. So children, they have something called as milk caries, and if you have children in your home and you can simply pay a little attention, you will find that they have like the front tooth, especially the upper one, or we can say the superior front tooth teeth. You will find like there is a whitish decay. Okay, uh, you will find them. That is called as milk caries. Why? Because these are the children who are bottle fed. Okay, so there is prolonged bottle feeding. Okay, especially when like even my children, when we put them onto the bed, we give them bottle. Okay, and because of that they have the decay of the front tooth. Okay, that is called as the milk caries. How we can avoid that? Of course, by restricting bottles at the bedtime, and clean their teeth before going to bed or after the last feed they had, and minimize juices as well as the sweetened pacifiers. You can also clean their teeth by soft clothes. Okay, or you can tell them to brush their tooth. Okay, like every day, especially after taking meals. Okay, so this can be done. So guys, that's all for today's lecture. And then now, next week we are going to start with more important topics of pediatrics. Okay, um, and we are going to discuss, like, then we will go system wise. Okay, discussing different topics. So thank you so much for listening.